In this sketch, we're talking about the greatest of all blood vessels, the aorta. And what better representation of this great vessel than a great, majestic oak tree, studded with a tree fort, of course. Specifically, we're going to explore this mega vessel right at its origin. The aorta begins immediately after the aortic valve in the heart as the aortic root, bringing freshly pumped blood superiorly as the ascending aorta, just like this ladder will take you upwards to the next level of this tree fort. And remember those A-shaped rungs. They're pointing upward for ascending, but also for something else that we'll get to at the very end. The right and left main coronary arteries immediately come off the aorta here, so close to the valve that the leaflets actually block the coronary ostia when the valve is open. These two lovebirds and their crowns, like coronation crowns, should remind you of the coronary arteries, and their floating hearts should remind you that the coronary arteries supply the heart. The ascending aorta is relatively short and transitions into the aortic arch, which arcs dorsally, or towards the back, and towards the left, just like this arched bridge is doing, to connect the ascending and descending parts. Recall that the aortic arch contains baroreceptors and chemoreceptors to monitor blood pressure and chemical composition sensed through the vagus nerve. To help you remember, we've dangled a barometer off the side of the bridge. You'd have something to monitor the weather when you're in a tree fort. Looks like Jim the octopus is trying to escape. That's what you get for keeping an octopus in a tree. The aortic arch also gives off three very important arteries. The first of these branches is the brachiocephalic artery, also called the innominate artery. We've symbolized this with a braking branch and a cephalopod. This is importantly not a paired structure and comes off of the right side of the aortic arch, as if any other cephalopod could be as great as Jim the octopus. Note that we're talking the right side here, but you may notice that the braking branch and octopus are on the left of the bridge. This is an important distinction because when you're looking at the patient, their right is on your left, and we always discuss anatomy as if you're looking at the patient. Oh, grabbing a couple of snacks before trying to escape, eh? Clever cephalopod. The brachiocephalic artery acts as a common trunk for its two branches, the right common carotid artery, demonstrated by this caret for carotid, which brings blood superiorly, supplying the head and brain, and the right subclavian artery, shown by this clavicle-shaped sub-sandwich, supplying the right upper extremity. Now, we're not talking about a grinder or a hoagie or a weck or a hero. It's a sub because we're trying to help you remember subclavian artery. And also because it's a sub. Hot take. I know. Over on the left side, and remember it's the patient's left again, the left common carotid artery and left subclavian artery come off directly from the aorta. No shared trunk here. So instead of one cephalopod, we have two separate kids on the bridge itself, chowing down on another carrot and clavicle-shaped sub-sandwich, respectively. Let's take a moment to talk about subclavian steal syndrome, when one of the subclavian arteries steals blood from one of its own branches, the vertebral artery. So we have this kid eating the sub, stealing from this new kiddo climbing up the rope. Hey, don't those knots look like vertebrae? See, the bilateral vertebral arteries ascend through the vertebrae to supply blood to the brain, both contributing to a single midline artery, the basilar artery. This means they're connected, which is normally fine, but if the subclavian artery is blocked, like from atherosclerosis, it loses downstream pressure. If the blockage is before the vertebral artery takeoff, this vertebral artery also has reduced pressure. Because the contralateral vertebral artery has normal pressure, this ipsilateral vertebral artery and subclavian artery end up stealing blood from the normal vertebral artery and basilar artery to supply the ipsilateral arm, since blood always flows towards the lowest pressure. Note that this reverses the flow in the ipsilateral vertebral artery. Patients start out asymptomatic, but as it worsens, they can get ischemic symptoms in either the arm or the brain, or even both. All right, so after the takeoff of the left subclavian artery is the descending aorta. The place where the arch and descending portions connect is called the aortic isthmus. The aorta here is tethered by the ligamentum arteriosum, a remnant of the ductus arteriosus from fetal circulation, to the pulmonary trunk. You can see this tether ball got all twisted up on this rather lung-shaped tree branch. This tethering makes this part of the aorta immobile and fixed, whereas the rest of the aorta, especially the descending aorta, is relatively free. Thus, the isthmus can tear during sudden decelerations like motor vehicle accidents called traumatic rupture of the aorta. And yeah, it's as bad as it sounds, as most people die at the scene of the accident and don't make it to the hospital. The isthmus is also where coarctation of the aorta happens, in which the aorta is narrowed, usually due to abnormal congenital development, which causes a whole host of problems that we are not going to get into right now. Just know it happens here at the isthmus, so we've got this tightly tied Arctic puffy jacket to remind you. See how it's tied so tight it's narrowed their face hole? Just like how coarctation narrows the aorta. After the isthmus, we're into the descending aorta, the last part of the thoracic aorta, symbolized by this descending zipline. Didn't you always want a zipline down from a treehouse? From here, multiple arteries go out to most of the thoracic organs, including to the lungs as the bronchial arteries, esophagus, pericardium, diaphragm, intercostal spaces, and even the spinal cord. Like this zipline is branching off to other platforms. It's like a choose-your-own-adventure story. Though I'm not sure how to control which one you go to, but then again, I guess blood cells don't get to choose either. The descending aorta at this point lies posterior to the esophagus, affectionately called the goose. So we've got a goose flying in front of the zipline. Because what's a little zipline without obstacles? Boring. That's what it is. This is important, as transesophageal echocardiography is able to visualize the descending aorta by turning the probe posteriorly. Finally, there's one last pathology to mention that involves the whole aorta, and that's aortic dissection. The idea with dissection is that the intimal, or innermost, layer of the aorta gets torn, and then blood pushes into the media, the weaker middle layer, pushing aside connective tissue and creating a false tract called a false lumen. Imagine pushing your hand into the hole between the tree and that peeling bark, and then pushing down to continue the peeling. That's what the blood does. Since blood from the aorta isn't getting where it should be and can actually block off what little normal flow there still is, this gets really bad really quick. There are several classification systems, but the Stanford system is the easiest to remember. If the dissection involves anywhere of the ascending aorta, including the arch, it's a Stanford type A dissection, which you can remember with A for ascending, and also these A-shaped ladder rungs. See, we told you they'd be important to remember. If it's only in the descending aorta, it's B-shaped. So check out these B-shaped descending zipline handles to help you remember that. And we'll finish up with a quick summary. The thoracic aorta begins at the aortic root, giving off the coronary arteries. It then travels superiorly as the ascending aorta, and then into the aortic arch. The arch gives off the brachiocephalic artery, which then splits into the right common carotid and subclavian arteries. And then the arch also gives off the left common carotid and left subclavian arteries. Don't forget how the subclavian can steal blood from the vertebral artery in subclavian steal syndrome. Where the arch ends and the descending aorta begins is the aortic isthmus, and this is the site of coarctation and traumatic rupture because it's tethered to the pulmonary trunk by the ligamentum arteriosum. The descending gives off branches to all the organs in the chest and then enters the diaphragm to become the abdominal aorta. And remember that the thoracic aorta can have a dissection, where blood enters the wall of the aorta, creating a false tract. Young love. Reminds me of the bard. 2 coronary arteries, both alike in perfusion, in fair aorta where we lay our scene. From ancient plaques breaks the intima where dissecting blood makes surgeon gloves unclean.